It is important to get the imaging and the image intensifier positioned prior to commencing the surgery. The image intensifier is brought in and positioned with the base opposite the surgeon. The intensifier is then positioned in the lateral position. At this time, the image on the screen is oriented in a manner that is exactly the same as the patient is positioned on the table. Go ahead and take a lateral view, please. Here you'll see a plumb line on the screen. Here we orient the intensifier to give us a true lateral. This is achieved by obtaining first an exact lateral of the L5-S1 disc space by adjusting the wig-wag on the fluoroscopy machine, and then the orientation of the patient on the table, or by adjusting the airplane positioning on the table, the two iliac cortical densities are brought into line. As you'll see on this lateral view, the two iliac cortical densities do not overlay. However, with a slight adjustment of the patient, picture, 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 the two iliac cortical densities are brought exactly into a superimposed position. The image intensifier is then brought into the inlet view, and the angle and the height of the image intensifier are marked so the radiographer can easily go back and forth between the lateral and the inlet views. Go ahead and come to an inlet view, please. The dense anterior cortex of the sacrum is cleanly visualized, and the anterior cortex of the sacral bodies of S1 and S2 are superimposed. The marks are made on the fluoroscopy machine, and then the image intensifier is brought into the outlet view. Go ahead and come to an outlet view, please. Focus is made upon the neuroforamina of S1 and S2. The superior cortex of the neuroforamina looks similar to an eyebrow, and that can be easily visualized in this image. Again, marks are made on the fluoroscopy machine so that the radiographer can easily come back to this view during the surgical procedure. The next view is the outlet oblique view. In this view, the intensifier is angled approximately 10 to 15 degrees away from the operative side. In this view, the image intensifier is positioned so that it is tangent or in line with the sacroiliac joint, and also in tangent or in line with the lateral cortex of the neuroforamen. Go ahead and give me a picture there. Here you see that the articular surfaces of the SI joint are now in parallel, and you also much more clearly visualize the dorsolateral and lateral cortex of the S1 neuroforamen. Marks are then made on the skin prior to prep and drape of the patient. These skin markings outline the anatomic landmarks. The landmarks are the iliac cortical density, or alar line, and the body of the sacrum. Picture. Picture. The long, blunt guide pin is positioned over the iliac cortical density, and a mark is made on the skin. The pin is then repositioned so that it is in the center of the cortical body. Picture. 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 Another mark is made on the skin in line with the center of the cortical body. The surgical incision is made along the line of the midsacral body, starting 1 centimeter from its intersection with the alar line. The incision is typically 3 centimeters in length. The first pin is then positioned. The tip of the pin should be positioned within the middle third of the sacral body with its tip 1 centimeter caudal or distal to the alar line. Adjustments to the pin position are made in the lateral view. Picture. 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 The pin is impacted slightly to set the tip of the pin into the into the iliac cortex. The image intensifier is then brought to the inlet view. In the inlet view, the trajectory of the pin is adjusted in the anterior-posterior direction until the tip of the pin is aiming towards the middle third of the sacral body. Adjustments in this plane should be made in line with the surface of the image intensifier. The pin is then advanced slightly. Picture. 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 In that trajectory. Picture. Picture. The image intensifier is then brought to the outlet view. In the outlet view, the pin is adjusted until it is parallel with the S1 end plate. The pin is then advanced in the outlet view until it is just superior to the S1 foramen. If the pin is aimed towards the foramen, the pin is stopped short of the foramen. Picture. 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 The blunt dissector is then used to gently open the fascia and to separate the underlying muscle fibers. The dissector is inserted in line with the muscle fibers, inserted down to bone, and then gently rotated to spread the fibers. The soft tissue protector with the pin sleeve in place is then placed over the pin and is advanced until its tip contacts the ilium. The length gauge is then placed underneath the pin and is advanced until it is in firm contact with the pin sleeve. The length gauge is used to determine the appropriate implant length. In this case, the appropriate implant length is 60 millimeters. The pin sleeve is then removed and drilling is performed. Drilling should be performed under the outlet view. The drill is advanced under the outlet view until it crosses the sacral cortex of the sacroiliac joint. Fluoro. Care is taken to keep the drill collinear with the pin to minimize pin advancement. Picture. Picture. To maintain pin position, place the exchange pin in the back of the drill and slowly remove the drill under power. Confirm on the outlet view the position of the pin. Picture. The first implant should be positioned so that one of its flat surfaces is parallel to the alar line. The soft tissue protector is oriented in the lateral fluoroscopic view. The next step is broaching. Broaching is performed in the outlet view. The broach stop is typically positioned at 30 millimeters of depth. The broach is placed over the pin, maintaining alignment of the soft tissue protector. The broach is placed down to the surface of the ilium and is then advanced across the sacroiliac joint until 2 teeth are in the sacrum. Picture. Again, care is taken to keep the broach collinear with the pin. Picture. 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 The exchange pin is then placed in the back of the broach, and the broach is gently removed. The implant is then placed over the pin, bullet nose towards the patient. The implant is advanced with the impactor until the impactor is fully seated onto the soft tissue protector. Picture. 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 The impactor and the soft tissue protector are then removed, keeping the pin in place. The 15 millimeter fixed parallel pin guide is then used to help position the second pin. The pin guide is placed with the short tube over the existing pin. It is advanced to the ilium. The second pin is placed, and then the pin guide and the pin are repositioned in the lateral view. Come to a lateral, please. Picture. The pin is advanced, securing the tip in the cortex. Then the intensifier is brought to the inlet view, and the trajectory of the pin is adjusted. The trajectory of the pin should be pointing towards the center of the sacral body. Again, adjustments in this plane are made parallel to the surface of the image intensifier. Go live. Again, the trajectory is towards the center of the sacral body. Once the trajectory is obtained, the pin is advanced. Stop. The image intensifier is then repositioned to the outlet view, and the pin is advanced, taking care to stay out of the neuroforamen. Picture. Picture. Once the pin is close to the lateral wall of the neuroforamen, the image intensifier is placed into the outlet oblique view, which clearly shows the lateral cortex of the neuroforamen and also shows how far across the sacroiliac joint the pin has advanced. Picture. Again, the outlet oblique view clearly shows that now 2 parallel surfaces of the sacroiliac joint and the lateral cortex of the first neuroforamen, and in this view we are several millimeters lateral to that wall. I'm going to advance just slightly. The first pin can now be removed. The soft tissue dissector is placed over the second pin, and the soft tissues are spread. The soft tissue protector with the pin sleeve in place is placed, again positioning it in contact with the ilium. The length gauge is utilized to select the proper implant length. In this case, the appropriate implant is 50 millimeters in length. The pin sleeve is removed and drilling is performed. Again, the drill is advanced until it just crosses the sacroiliac joint. Picture. The exchange pin is placed and the drill is removed. The C-arm is brought into the lateral view and the orientation of the soft tissue protector is performed. Picture. 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 The fluoroscope is brought back to the outlet view and broaching is performed. Picture. 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 The exchange pin is placed and the broach is removed. The second implant is then placed. Again, the bullet nose towards the patient. The impactor is utilized. Picture. And advanced. Picture. Until it is in contact with the soft tissue protector. Final position is confirmed with the outlet oblique view. Which shows the implant well lateral of the foramen. Picture. The impactor and the soft tissue protector are then removed, leaving the second pin in place. The variable parallel pin guide is used to place the third pin. The trajectory of the third pin is typically between the S1 and S2 neuroforamen on the outlet view. The short tube of the pin guide is placed over the second pin. Pin guide is advanced till the long tube is in contact with the ilium. Third pin is placed. And here, picture, you see that the trajectory would be between the S1 and S2 neuroforamina. The image intensifier is brought to the lateral view and final adjustment of the third pin starting position is made. The third pin is advanced into the cortex and then the image intensifier is brought to the inlet view and the trajectory of the pin is adjusted. Inlet view. Pin adjustments are made in the plane of the surface of the intensifier. Picture. 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 Second pin is removed. The intensifier is brought to the outlet view. And the pin is advanced across the joint. Picture. 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 Drilling and broaching of the third pin are then performed in a manner similar to that performed previously. The length gauge is used to determine the appropriate length implant. In this case, the appropriate implant is 40 millimeters. Picture. 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 Picture.
Push that in just a smidge.
Picture.
Perfect. Good. Come to the lateral, please.
40. Picture. 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 Very gentle. Picture. Picture.
Bring your hand up a little bit.
Picture. 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 The outlet, outlet oblique, inlet, and lateral views. An implant may be repositioned utilizing the removal adapter. The blunt tip is placed into the trailing end of the implant, and the threads on the removal adapter will engage the threads on the implant. Picture. An implant may then be withdrawn and repositioned. Picture. Picture.